All right, welcome back. We're joined by Dr. Lorio, and you've heard us give her qualifications, and we're talking very seriously about, we live in the outside world here. We're seeing people, we're talking to friends who are doing pretty good, but in your world, when you get through those hospital doors, it's a whole different ball game, and I'm trying to relay some of that to the audience about what do y'all see? What do X-rays show? What are y'all seeing as doctors where you go, wow, we're in a war here?
Yeah. So the X-ray with COVID patients progresses pretty quickly. You can have a perfectly normal X-ray the day before, and it looks nice and clear and beautiful. There's black lung fields, which tell me that they're full of air, which is what I want to see. The margins are nice and crisp. That tells me that there's nothing floating around in the lung that's blocking your ability to get oxygen where it needs to go. And then very quickly, those lungs start to fill up with proteinaceous or protein-filled fluids, infectious particles, blood cells trying to fight the infection, and they become very hazy. And at this point, this is where patients need oxygen. The patient on this X-ray right here is someone that was in our ICU and was on a BiPAP mask. So that's this mask right here. That's someone wearing this mask on their face. It straps on with these straps back here to the back of their head, and it pushes air into their lungs, similar to if you were sticking your head out of a window of a car driving 40 miles an hour. That's the best way to describe how this mask feels while you're wearing it. The next progression of the X-ray is as the lungs continue to fill with this fluid. You can see the next X-ray here. It has a lot of areas scattered throughout both lungs. And that's where patients end up needing to be put on the ventilator. And the way that we do that is we use something like this, a blade, to be able to open up the airway and be able to look inside and get this tube right here into the patient's lungs. It goes through the mouth, down the throat, and into the lungs. It connects to tubing and a ventilator so that we can breathe for the patient completely. And one of the specific challenges that we've had for COVID patients is how best to ventilate them once they're on a breathing machine. There was a lot of controversy and debate early on in COVID about whether or not we intubate patients and what happens once we do intubate them, and we've learned a lot very quickly. But one of the things that has been a driving force for us managing critical care patients is that these patients have to get oxygen in, and no matter how much we try to avoid putting them on the ventilator, at some point we have to concede and say that the ventilator is the next best step for this patient, and then support them through that.
How difficult is it when you know and when they know they're going to get the vent, and it's very traumatic? You just showed that a while ago, and I could tell it's painful for not only the patient, it's painful for everybody on the floor, everybody in the room. But when you're getting that, are there any percentages of, is it sort of, I don't know, or are we gambling at that point of how they're going to do, or do y'all have different levels on the vent that you could see?
So that comes into how we manage patients on the vent, and most of the patients with COVID and pneumonia, they fit into the category of something called ARDS, which is acute respiratory distress syndrome. It's where the lungs are so full of fluid that they're not able to get oxygen in, and so we have essentially protocols and guidelines that help us navigate how to best ventilate these patients. And one of the things that I talk to the families, and I try to reach out to families every day while their loved ones are on the ventilator, because I know that they can't talk to their loved ones, so I want them to know that someone is looking after them. I explain the different pressures that we have them on the vent and what they're at right now and what the goal is, so that we can start talking about when we get them towards working off the ventilator. Some of those pressures can get very high, and it can cause trauma to the lungs. It can cause scarring and fibrosis down the road, even if we get them over the hump of the COVID infection. And then we also use oxygen levels, sometimes up to 100% on the ventilator. And one of the biggest rules in critical care is, sometimes too much of a good thing is bad. And oxygen levels, when we're giving you oxygen at 100%, that can be toxic to the lungs over time. So we want to try to do everything we can to work somebody down from the pressures that are so high and the oxygen levels that are toxic as quickly as we can. And we've developed as a team at Terrebonne a very good protocol for treating these patients and making sure that we can work down those oxygen levels as quickly as possible.
All right. I want to thank Dr. Lorio. We're going to be back. We have a lot more to talk about. It's a very important show. This is a show you need to share with everyone. If you're on Facebook, YouTube, share this program. It's very informational. We'll take a short break. We're coming right back. Don't go away.
There are many strengths in our cancer center. I think one of the biggest is patients don't have to go elsewhere to get technology for their diagnosis and treatment of their cancer. Our treatment machine, the linear accelerator, allows us to pinpoint and treat cancers with more accuracy than ever was possible before. Mary Bird Perkins Cancer Center provides leading-edge technology with the highest quality care and the best treatment options unique to each patient.
And welcome back. We're going to wrap things up in this segment, but very important segment we had tonight with Dr. Andrea Lorio, Terrebonne General Health Systems. We appreciate you coming. We know it's been a tough go for not only you, but the whole medical system. Everybody in the whole nation is really struggling with this. I would be remiss if I didn't ask this, because I hear the talks. I feel the seriousness of your voice. When I talk to Ms. Peoples, I feel it. We can go down the line. Every doctor, I feel it. Oxygen tanks, testing, medicines, hospital availability. Where are we with that right now?
Yeah, so hospital availability, if you come to the emergency room, you're gonna have a long wait. We triage patients based on severity of illness and what they need. We are mobilizing staff. We're using resources creatively to try and make sure that we can triage patients as quickly as possible so we can move them to where they need to be as quickly as possible. But we're getting to the point where we don't have places to put patients because we don't have staff to be able to take care of the patients. A bed in the hospital is useless if you don't have a nurse to take care of the patient, if you don't have a respiratory therapist to be able to give them a treatment. And so we're getting to the point where, our ICU beds themselves are full, which means ICU patients are being held in the emergency room, which means that, we're having to use resources in a way that is taking care of the patient as best we can and sticking to, the highest level of care that we want to provide for all of our patients and that we expect to provide at our facility. But we're getting to the point where it's harder and harder because resources, both people resources, medications that we typically use for the treatment of COVID are getting harder to come by. Orders are coming late or they're not filled completely. We have difficulty with getting supplies, basic supplies, BiPAP masks, tubing, to be able to take care of and use for patients.
Mm-hmm. With the few remaining minutes, I want to touch on the meds. I want to get your opinion. What's the protocol? What's working for y'all at Terrebonne General Health System?
So what's working for us, the best system that we've had is working together very closely as a team. Myself, my partners intensivists, as well as the hospitalist team. We've come together and developed a protocol that includes the antiviral remdesivir, as well as anti-inflammatory medicines, including steroids and baricitinib, to help reduce the inflammatory burden as well as the infectious burden of the COVID infection. And then also providing patients with antibiotics to treat for potential bacterial infections that are superimposed on the pneumonia that we see on their images.
Let me ask you this. I heard someone talking a couple of days ago that, and I'm not going to say it because we automatically get kicked off of YouTube if you say the word. So I'll just say it's common knowledge that you can get these at the feed store, and they're out there and people are mixing their own dose. That's different than a dose if a doctor would prescribe. It's two different animals, isn't it?
Yeah, so animals, dogs, cats, horses, humans, we all have a different metabolic rate. And so using medications that are marketed for horses and dogs in the human population, there's also different degrees of FDA approval for these medications. You know, how much is extra additives in the medication versus what the actual chemical compound of the anti-parasitic agent that you're talking about is in the medicine that you're buying online or at feed stores and different places. And so it really is not safe. In addition, you know, there are clinical trials that are looking at the utility of those drugs and medications, but right now there's not enough evidence to support that it actually helps. A lot of the trials and evidence, the hypothesis of how it works is based on in vitro studies, which looks at completely different doses than what typical human prescribed doses of these medications are. And so their effect is unfounded or not effective at this time.
All right. Doc, I want to thank you for coming on. I want to thank you and the entire hospital system for what y'all are doing. I know y'all are under a lot of stress, and I think we all long for a day where we don't have to sit here in the news desk and talk about COVID. We could talk about other generalities and good things that are going on, but just thank you for what you're doing. I know you didn't sign up for this. Ms. Peoples didn't sign up for it. The hospital didn't, but y'all are there and y'all are doing it, and we appreciate what you're doing, and we appreciate you being so transparent today.
Thank you.
All right.
It's
Keep up the good.
what we do.
Yeah, you're right. And yeah, you can see a very candid interview tonight. And Dr. Lorio, you could feel her emotion at times on what she was saying. She's on the front line. She's in the hospital. And that's why I'm really trying to stress to people, and myself included, we're on the outside. And we go around and we see people and they're functioning very well. There's a whole nother world going on, and it's inside the hospitals in our area. And I want you to be cognizant of that. And when you see healthcare workers, thank them, because it is a different ball game inside those walls. Thank you for joining us. We'll see you again soon.